This is on the surface, or at most, really, a very simple contract law bill, and that's why it's before you. But I'm going to give you some background before I talk about exactly what the substance of the little bill itself is. As you all know, we have an absolute crisis in healthcare in Rhode Island, and one of the many, many components of this crisis is that we have no primary care doctors. We have a hemorrhage of primary care doctors. And one of the reasons for this is because they cannot afford to be in business with the reimbursement rates that they get, with the commercial reimbursement as well that they get. They are getting $37 for a Medicaid visit. And that simply doesn't keep the lights on in private practice. So what we have is doctors that are going over the border to open practice. Massachusetts and Connecticut are the beneficiaries of that. Or they are retiring, lots and lots. We're not replacing them. Or they're going concierge. If you're not familiar with what that is when a doctor takes his practice of 2,000 patients, accepting commercial insurance and Medicaid, and says, I'm only going to see 100 patients. They will each pay me $3,000 a year. I'm a businessman as well as a doctor, and this is the only way I can keep my business open. I don't have the data, but it is happening more and more, and I will tell you truthfully, Rhode Island is a target market for a company called MDVIP. They're looking to encourage more of our doctors to do this. We had maybe 800 or 900 primary care doctors in Rhode Island. We're down to a bit over 3. The waiting, the time to get into Brown, which is corporately owned, not privately owned, 22 months. So I think we all understand that there's a problem. And we're having many discussions in our chambers and our committees about solutions. And I come to you today with a very out-of-the-box solution that was brought to me by 2 MDs who have done this. They have managed practices successfully, and they're struggling with it now. I'll allow them to give you their background, but I can speak to the fact that they owned more than 20 practices at one time. They're very big. They're very good businessmen. And so more than the healthcare aspect, we're speaking to the business end of this and how important this bill would be to protect them. So essentially, the bill allows for something called a practice support fee. You can think of this as concierge for all. You can think of this as membership medicine, but those terms aren't really appropriate. This is very much smaller than that. It is already being done by our hospitals. When you're running a business, such as a medical practice, you have to pay all of your business expenses, the back of the house. So the doctor who's given $37 for that Medicaid business not only has to pay himself, he has to pay his medical assistant, he has to pay his receptionist, he has to have people on the phone doing all of these egregious prior authorizations, he has to pay rent, he has to pay malpractice experience. You get my point. How are we doing this for these small amounts of money? They're not, and I'll repeat myself, this is why they're leaving. They cannot afford to be here. Okay, so hospitals faced the same problem. They were not able to stay open based upon only provider fees. So they are now allowed to have something called a facility fee. And facility fees are really expensive. They can be about $250. But what that money does for the hospital is it pays the back of the house. It gives the hospital cash flow. It allows the hospital to operate as the business it is and keep the lights on. So this practice support fee is like what hospitals are doing with the facility fee. But it's very, very small. If you look at the bill, you'll see that the fee that we're asking to allow doctors to get is capped at $10 a month, $120 a year. And that number surprised me when I was first approached with this idea. I said, there's no way you can do this for that. But we have the data, we have the numbers, and whether it's a small practice, 1 doc, 2,000 patients, or 20, 25,000 patients, this can be done for $10 per patient. And it is direct pay. Unlike the facility fees that are $250, where Blue Cross pays, where Blue Cross pays that fee, this is direct from the consumer to the doctor. That's why it's similar to membership medicine. kind of lost track of my thoughts here. Oh, this is important. Commercial patients would be asked to pay this fee. Medicare and Medicaid paying patients would be carved out. You can see that's in the bill. They would not be asked to give this contribution or support fee. Commercial patients only. This is designed on purpose to keep the doctor in business serving the underserved. So I've had some, I'll be honest with you, some negative feedback where people say, how dare a doctor ask for another $10? The optics of this are terrible. We are not giving him any more money. We already pay. Some of my testimony in opposition is it's too expensive. Okay, well, the choice is if they go concierge, you have no doctor. We're contributing to keep them open. So some of the witnesses I brought today are Dr. Jonathan Martin and Dr. Frank D'Alessandro from Greenwich Bay Medical, but I also have Dr. Nathan Baraha from Anchor Medical. And if any of you are familiar with the recent headlines and how Anchor Medical had to close, I believe, and he can correct me, 25 or 30,000 patients. This might have saved them. I'm not kidding. In addition, we have other places that are about to go under. There's a large medical practice in the northeast corner of the state who has said that they're in big trouble, and they have 15,000. What's going to happen if we don't get some cash flow into these enterprises? It's not about greed, it's a Hail Mary. So that's the pitch for why this is important. And the last piece I want to give you is the bill itself is merely contract law. When a doctor enters a contract to accept insurance, such as Blue Cross or Aetna, the insurer is putting in a word, standard contract law, saying, oh, and by the way, you can't get any practice fees. In my opinion, the insurer is stepping on the business rights of the doctor. Like, why is that contract law allowed to be there? It's standard contract law. If you don't allow them to do that and you don't sign it, well, then you're not collecting insurance. So the doctor's stuck. This bill would simply eliminate that contract language, that little bit where the insurer has his thumb on the back of the doctor, just preventing them from doing it. It would cost the insurer nothing. It will not cause premiums to increase. They really have no opposition, or they should have no opposition, except they want to control private enterprise. So I think those are good reasons to consider this. I want this to pass because I really care about healthcare, because I really care about people. I understand, and I'm using the word optics again, that it's a difficult thing to tangle with when we're asking people for money. So I do have some suggestions of a sub-A already that I think are good. Anything that I can do to redraft this and get it to be palatable and passable and work as a solution for Rhode Islanders, I'm willing to do. So if you've read the bill, I would like to say that some of the changes I'll be making is that this will include nurse practitioners. It was mistakenly written to include doctors only. Nurse practitioners are a very, very important part of primary care. Not 30 days, but 60 days before finding another doctor, because I've been told that's the standard. And that there would be a family limit. And this one's really important because one of the letters of opposition said, well, if you're husband and wife and your 3 kids and you have a dermatologist, no. First of all, it's not specialist, it's primary care only. That's what we're saving here. But it's valid. If you're a married couple and you have a couple kids, it's not $10, it's not $120, it becomes $500. So we would write a family cap into this because, again, this is to solve, not to harm. We want this for good, not for bad. I know you're all tired. I'm going to bring forth these witnesses. I hope that you can engage some questions with them, because this is something that I think if we tangle with it, maybe we can do some help. I have one more piece. Nothing about this is mandatory. We're not passing a law where a doctor has to do this. I'm simply saying allow them to if they choose. If your doctor wants to do it and you don't like that, you can go to another doctor who doesn't do it. Just like you can go to an expensive gym or a less expensive gym. You have options in the market, let the market bear it out. But it is not mandated on the doctor in any way. And sure, plenty of them will say, I don't need to do that. I don't want to do it. But more likely, I think many of them will appreciate our efforts.